Well, we've had such a fabulous morning, great speakers. I'm hearing wonderful things about all three breakouts. I don't know how you can run all three at one time, but we'll try. In the meantime, we are so fortunate to have our lunchtime speaker, Janice Sunderhaus, who is building her talk, blends beautifully what we heard from John Auerbach this morning, as well as the other talks and what we're doing. And in your brochure is the bio on Janice. I'm not going, because we're running late, I won't go into everything. I'll let you read it. Yet you know she's the Chief Executive Officer for Health Partners. It's on the screen of Western Ohio and from Lima, Ohio. But she also is over several, how many federal qualified health centers? Numerous awards she's gotten over the years. She works with CDC, where John Auerbach was from, before Trust for America's Health, and she's leading many different venues within this state of Ohio in the population health area and patient-centered medical home. So, Janice Sunderhaus.
Thank you very much for having me here today to share a little bit about our organization and what I'm calling an experiment in integration. So that experiment is the key word. Let me see if I get my clicker to work. I'm going to take you back a little bit to the early 1990s when Healthy People 2000 began as a national health promotion program that was guiding the America towards living longer and healthier lives. Healthy People 2000 identified objectives to improve the health and develop targets that could be measured. The overall 3 goals of Healthy People 2000 was to increase the span of healthy life, to decrease health disparities, and increase access to preventive services. During this time, I was a public health nurse working with a low-income African-American community. The country became very aware of health disparities, and headlines like you're seeing on the screen became very common. But this was nothing new to the people in my community because they lived with the health disparities every day. In 1996, the Cleveland Plain Dealer did a series of articles looking at health disparities across the country and really targeted it on communities that had the widest gap. To our big surprise, Lima, Ohio, just 2 hours up I-75, had some of the widest gaps in health disparities in the nation. Faced with that sad reality, we had to do something. Many people didn't believe the data initially, but as we began to dig into the Ohio Department of Health's data warehouse, we showed the stroke death rate was unbelievable for African American women, and cancer death rates from late diagnosis was very common. From that, the Southside Planning Committee was formed, and I was one of the key organizers. I always say it's dangerous to put a public health nurse out in the neighborhood with a computer. You begin to research, and I ask people if they believe in love at first sight. Do people believe in love at first sight? Well, the first time I met community health centers, I fell in love. Community health centers were created during the War on Poverty in the 1960s. They are community-led organizations that develop primary care where the users, the patients, are the boss. Their mission is 100% access, and that means access to the right person you need. So if you need a dentist, access is not an ER. If you have diabetes, access is not an ER. If you are having mental health problems, an appointment in 6 months is not access. And 0% disparities. How do we bring those communities up? But it really was that consumer-driven board of directors that I really loved. Health Partners formed our original board in 2002. We had one retired family doc, Dr. Jean Wright, was our board chairperson. We had a director of nursing who was our treasurer. They were the only two professionals of our board of directors, and the rest of them were community members, many of them who were the low-income people who did not have access to health care. We were known as the bunch of amateurs. I didn't have this in my speech to say, but both hospitals had lotteries in their medical staff services as to when we were going to go under. And they had money on the board, and I always say, we outlived those pools. Why didn't I ever get the money? So, with $5,000, we got a loan for a physician's salary. We got a National Health Service Corps loan repair, and we opened in July 2003. We had one doc, one medical assistant who did the front office, and I was the unpaid nurse. But patients flowed into us. We had 20 patients a day by the end of the first week, and we didn't have phones yet. By the end of a month, we were seeing 35 patients a day in one exam room that was donated to us at a Health Start building. After 18 months, we received a FQHC grant under the President George Bush initiative of expanding health centers. And we had it made. We had money. All our problems were gone, right? So, you know, money solves everything. Well, that's what you think. As patients lined up, we could not find another doctor who would join our team. We recruited, we interviewed, we brought them to him, we shared our story, and we had no takers. Each day, dozens of new diabetics and new hypertensive patients streamed in. The children in our community had never been to a family doctor, had only seen the emergency room for all their health care, and then the health department for their shots over here. We hired 2 nurse practitioners in a climate where we only had one nurse practitioner in independent practice in Lima, Ohio at the time. And that was in 2006. Whoop, whoop. You're going to love my numbers later if I get a cheer for that. We had one nurse practitioner. Our hospitals wouldn't accept our orders. We couldn't get referrals. They'd say, where's the doctor's signature on this to specialist? But we persisted. Our new MPs got down to work fast and worked very hard. The patients were very complex that we were seeing. Most of them had not had access to care forever. The mental health needs that we were seeing within that patient population was severe. And we knew, well, I knew, I was still the nurse in the beginning, that our providers, our doc and our NPs needed help. After 6 months, we opened an on-site pharmacy, and our pharmacists began to do medication therapy management in their spare time. And I hired our first licensed independent social worker to help manage those mental health patients. By pure necessity, our first team was formed. And I usually say our LISWs, are there any? Okay. Our first LISW, we had an office, and she had a stuffed animal, and we had a little refrigerator, and she had bottles of water in it, and she had appointments booked all day, and she saw 2 people a day. And we said, well, this isn't working. So we moved her office to right down the hallway, an office next to the primary care team. And she went up to about 3 or 4 patients a day. And I said, I can't make payroll at this. So we kicked her out of our office, gave her a clipboard, and we said, you hang on the side of that countertop with that doc and nurse practitioner. And she went up to 7 and 8 patients a day immediately. So teams. We all talk about teams. Everyone's been on teams. We've been on good teams. We've been on bad teams. We're really lucky if we get to be on one great team in our life. You know, those teams where we can read each other's minds, where we know what that person needs before they know what they need. You can tell by the way they walk in if they're having a bad day and didn't sleep because the baby kept them up. And you know why you're working. You're working on a shared common goal. Makes perfect sense. Why healthcare doesn't go to teams? They're efficient, they save money, they get improved outcomes. I'll tell you why we don't do it, or why it's not getting done. Because it is super hard work. There are barriers to care all over the place, and it's the stuff that we don't always like to talk about. Who's in charge? Who gets the final say if there's disagreement in patient care? Who's doing what and when? What if today I got to get out of here on time and I don't want to do collaboration? I just want to get through my patients. The first day we had an LISW disagree with a physician over patient care, we thought we were going to have a breakdown and knockdown in the hallway. So as we began to struggle on how do we make this team concept work, we began to look outside. And one of the things we said, we don't have a shared mental model. So some of the work that having people do training together really was getting that shared mental model of what are we in? And for this, all those penguins know we're trying to get fish. But we didn't have a shared mental model. So that was one of the goals that we did in administration, is how do we get this shared mental model? And I don't believe in recreating the wheel at all. How many people in the room have heard of team steps? Anybody doing team steps now? Yeah. Well, I don't believe in recreating any wheel that's been out there. And team steps was developed by the Agency for Healthcare Research and Quality. It has over 30 years of best practices and research to prove that it does work. It's been applied from everywhere from military medical work out in the fields to across hospitals and in outpatient and primary care. What I loved, because we're a FQHC, we're broke most of the time, free training, and guess what? You can't be a prophet in your own hometown. So I got to send my people out to hear from the experts why we should be doing this. We started with 3 people, probably about 5 years ago. And now we have probably over 35 people who have been trained by the trainers outside of our organization. We continue that work with daily briefs. One of the things that we did, this is mostly a clinical piece, and we looked at it and we said, we all need to be doing daily briefs. So we start our day across the entire organization at all of our sites with a daily brief. That includes administration have briefs, finance and billing have briefs, and all of our clinical services have morning briefs. Something goes wrong during the day, we break and have huddles. We work together on all of the team step skills. And we include that as a standing part of our monthly staff meetings. Every staff meeting has a team step activity that is hands-on with our teams, that has reinforced the tools that we use regularly. It has taken us 4 years of consistently working with team steps before it actually has permeated our culture. And the change that we have been able to see with that change in the culture when it's actually finally part of what we are is huge. The beautiful thing about this, we talked about those barriers to care or barriers to teamwork. Team Steps has cool tools and strategies that attack those barriers. And the outcomes are really that shared mental model, that your teams are more adaptable. We look at our work through the focus of teams, and the trust within those teams makes a big difference. In the past, if there's teams weren't getting along, they would come to your manager and they say, we don't like so-and-so, or so-and-so embarrassed me in front of a patient, or they disrespected me, or they didn't take my advice, and then the managers would typically get in and try to referee. Now, when that happens, the manager basically says, what team steps tool could you have used? So we say, could you have cussed at each other, which is, I'm concerned. I'm uncomfortable with this situation, and this is why. And it's a safety or patient care issue. But we actually don't do it. We have them do it. So we all love to be out of the middle of it. So It has significantly changed our culture, but it took time and effort. And Team Steps is not for the weak at heart. It doesn't happen in 6 months. But our teams are working together in a different way and much more positive, which has allowed us to move forward on other initiatives. There's lots of other things that we had to do integration, and I'm just going to run through a few of these. Workspace. You cannot take a primary care provider, a LMA, a LPN, add a clinical pharmacist, a behavioral health person, and not provide more space for them to work, and 3 exam rooms, which is the typical 1-to-3 ratio for a primary care person, doesn't work. So we've gone to typically 4 exam rooms per primary care team, and sometimes 5 exam rooms. We've had to redesign our space to make that happen. Shared electronic health records. All disciplines, medical, dental, behavioral health, dental, pharmacy, dispensing and clinical, substance abuse, all use the same electronic health record. You'll hear from the people in the behavioral health world, you can't put that in the medical record. Well, I think that's vital to know if you have someone severely schizophrenic who is on medications and drugs when they're in the dental chair. So we've had to push through some people's uncomfortableness that really likes to prefer those silos. Standardized procedures and screening. This has had some pushback from providers. They say, you're taking away my independence. Why do every one of my patients have to be expert screening for substance and drug abuse? Because I know who to ask. So those options not to do are not part of our program. They're required. So every patient has an expert once a year. Every patient gets PHQ-9 for depression and anxiety. Every patient has med reconciliation. If they have 5 or more meds, they are automatically referred to a clinical pharmacist to work on their medications. Every patient has dental screening. So it's not, you don't get to pick and choose. It's part of what we do and how we do it. Health outcomes monitoring. We monitor health outcomes. We know data backwards and forwards. So, and I think someone said earlier, everyone thinks they're doing better until they see the data. And that's really the truth. And there's nothing like showing high-performing people their data that is bad to get them moving in the right direction. So we do health outcomes monitoring for diabetes, hypertension control. We do PAP and colorectal cancer screening, immunizations, depression, childhood dental sealants, and dental phase 1 completion, which means all diseases out of their mouth. It's one piece that we've not heard one person mention oral health. And as we continue to focus on, say, our patients that have their A1Cs out of control, the most easiest and simplest treatment is to have their teeth evaluated. I will guarantee there is gingivitis, they have cavities that have been unattended to. You get those teeth taken care of, you can slow down their meds, their A1Cs come down beautifully. Simple, easy, happens almost too easy sometimes. And transparency in our clinical quality scores. Everyone gets to see everyone's data. Oh, God, that makes everyone nervous. You mean you're going to show the best performer, the biggest leader in the department, whose immunization scores for their adolescents is the worst? Yeah. Those are uncomfortable conversations. But the work done in Team Steps really helps you to move forward through all of that. And I will tell you, I've sat in meetings where administrators had looked at each other and said, are we really going to put this up for everyone to see? Yes. So all of that has allowed us to move forward on the same thing we've all been talking about. It is that creating that patient-centered medical home. And ultimately, I say I'm very lucky because a lot of people aren't sure what their jobs are. I am one of the lucky people who know exactly what my job is. My job is to improve the health of my communities and save the government money. If I save the government money but no one's health is better, what's the point? That's called rationing care. I don't want to do that. If I improve the health of the community and it costs so much, who do you think won't get care in the end? It's not going to be the poor people. They will be the first to get it rationed away. So my job is simple. Improve the health of the community, save the government money. And there in the middle is that better health, better care, and lower cost. The triple aim. So having really worked on this collaboration, this interprofessional teams, has allowed us to kind of push then. Once the teams begin to function, they begin to monitor themselves and push their own quality. And we're really able to move towards that population health, the larger focus. One of the things that we've done is we've named a chief population health officer whose job is to look at all the comprehensive primary care programs, work with our community and our small community transformations where we have walkable, bikeable communities, safe roads to schools, where we're working with the schools to add physical education and salad bars. We have our high school, a group of kids we've been working with have just created a salad bar 2 days a week in their high school, and that's new for an inner city school. We're really working very hard with the health information exchanges to get that data across all the contingency and the whole stream of care. One of the great things is we're now, before a patient had to identify you as a provider, well, they go to the hospital and they say, who's your doctor? Well, the majority of my people don't have doctors. They have nurse practitioners. Well, the hospital's not going to put that in. Well, they're not part of the care team, or they're under somebody else. So we wouldn't be able to know who, even when our patients would show up, we would never get that back on the ER list. So one of the great things with the health information exchange is now I provide them a list of my patients. Doesn't matter if they identify me or not, I'm going to get that information back. That provides me with real-time data so I can intervene in that ER use or that hospitalization immediately, not having to wait for 3 months worth later for claims data. So one of the things we're really looking at is we've looked at this really transparency in data and said, why do some of our teams function so well and some of them are really struggling? So colorectal cancer screening is one of our targeted QI efforts, and we have a range of one clinical team was about at, these low-income people. So one group was at 23% of their patients had screening done. I had another team that was 81% of their patients had already been screened. So we said, wait a minute, what's going on? So we were able to bring that team in. They were all trained on team steps prior to. They were to do mapping of what they were doing differently. We identified 2 best practices that they had just organically done themselves. We were able to take that. What we have at the health center is the Golden Toilet Trophy. It's actually a trophy that we passed around to whoever was doing the best. But what we've been able to do is take those organic interventions that the team developed, spread that to another team at the same site, then spread that to all of our sites. And we haven't gone out and gotten 12 golden toilet trophies, but that's the concept of it. It really allows us to spread best practices within the health center much quicker. So starting out with $5,000 about 14 years ago, these are our community health center sites. We were funded with 2 sites prior to the Affordable Care Act. We now have 11 sites. Of those sites, 5 are completely comprehensive primary care sites, and those are the 5 communities we're anchored in. That means medical, dental, behavioral health, on-site pharmacy, clinical and dispensing pharmacy, and substance abuse. We offer opiate treatment in 4 of our sites, and soon to be our other last one. We have 3 school-based sites in those communities where we have full community health centers, and we have 2 sites where we are located within community behavioral health agencies doing the primary care needs for people living with severe mental illnesses. So that biggest growth were, I would say 3 of those new sites were based on new grant opportunities that were from the Affordable Care Act to health centers. The rest of those, the other 6 of those were basically on the back of Medicaid expansion. So when we talk about Medicaid expansion population going away, that very much puts probably my school sites in jeopardy and my co-location sites in jeopardy. So this is the screen that I usually get the most. So we're doing all of this work with 2.4 FTEs of physicians. I have 1 full-time clinical director and 3 part-time doctors. I have 18 nurse practitioners, 4 PAs. I have 19 LISWs, so we have about a 0.8 behavioral health person to every primary care team. And I have about 1 clinical pharmacist to 5 providers. Nationally, our nurse practitioner to physician ratio is about 7.5 NPs per doc. The national average is 0.67 to 1, and the state average is 0.5 to 1. So we are way abnormal. Abnormality, is that right? That's what they say to call me in Lima. So abnormality. So I want to show you, this is the growth of our patients. So we have almost over 30,000 patients. This is at the end of 2016. We're continuing to see this year, the last 3 months have been significantly higher than the year before. If we had been a physician-based practice only, we'd be lucky if we had 6,000 patients being taken care of. And when you have sick people standing in front of you, that is the necessity of innovation. Over 144,000 patient visits in 2016, and the typical patient of ours has a couple medical visits, a couple behavioral health visits, and always we try to get in a dental visit. When we include dental, all their clinical quality measures go up. So the truth's in the data. I have about twice a year, the hospitals throw a fit because Janice is running all these places with a bunch of nurses. And they throw out an email of alarm to the community and say they're not sure about the quality of the care that's being given. So I always say the truth's in the data. We are AAHC accredited, and all of our sites are medical home level 3. We received the Million Hearts Award. That's for stroke prevention, smoking cessation, and hypertension control. We've received that since 2015, and that's to meet the 2017 targets. We are in the top 25% of the nation in all of our health quality outcomes, and our target is the top national, which is the top 10%. We have an internal goal of doing that by the end of this year, so the pressure's on. This is the one I'm the most excited about and proud of. It's the Access Enhancer Award. We have received this for the last 3 years. And this means we continue to grow the number of patients we see who are receiving comprehensive services. So it's not just medical expansion, but it is medical, dental, behavioral health, opiate treatment, or substance abuse treatment. It is that primary care health home model, and we were the only one in the state of Ohio to receive that. Whoop, whoop. So how does this happen? What's our philosophy of how we do things? We've learned some hard lessons along the way. I always say we've made every mistake. I have a very short memory, though, so I usually forget the mistakes. So there are people out there who have the right heart for this work. And in the past, we would get nervous, and we'd be, oh, we have a hole, and someone's leaving, we got to find somebody, we'd hire the wrong people. We don't do that anymore. We hire the people with the heart and the why, and we will wait till that right person comes along. Patient-focused decision-making is always good for business. If you had told me 6 years ago that I would be doing opiate treatment for heroin addicts, I would have said, you're crazy. But guess what? I am in rural Ohio. People in Williams County, children are dying, and there's nowhere to get treatment. Well, how do you walk away from that? So one of my physicians basically left his primary care team. A nurse practitioner took over, and he goes 1 day a week here, 1 day a week here, 1 day a week here, doing the Suboxone and getting people established with care with a substance abuse treatment team with the clinical pharmacist. Together, the three of them are able to do that. And then what happens is we're able to transition patients once they're off of the buprenorphine or Suboxone onto Vivitrol, which is an IM injection, which is in the nurse practitioner's scope of practice. Those patients are transitioned directly back to their primary care team. Substance abuse is seen as nothing other than a chronic disease, just like diabetes, hypertension, opiate treatment, same thing. Change in healthcare is normal, so get used to it. This is not for the weak at heart. If you want to do the same thing you did yesterday, tomorrow, you need to get out, because that's not the way it is. We have to be able to move with the times, and I anticipate, I have always said since the Affordable Care Act was passed, there are times of feast and there are times of famine. So We're getting ready for the famine. We don't know when it will hit, and maybe it won't hit, but that's part of what we do. So how do we keep our core services? How do we keep our quality where it's at? And that's by being part of the comprehensive primary care programs and looking at the other ways to get paid, to actually do the per member per month and invest that into population-based health interventions. Every new program is a learning opportunity, and you should expect to make mistakes. If you're going to step out and do opiate treatment, and you'll be the first one in the state to do it, guess what? You're going to make a lot of mistakes, and we've done that. But our people in our communities have access to care. And when you have mothers calling you and crying on the phone, asking you, can you please get them a slot in your treatment, you're willing to make a few mistakes. And we say embrace technology. We love technology. It helps us do our work easier, but invest in your people. Your people are the thing that makes the difference. It's that reason that people come into primary care. It's the reason why the doc said, I want to see you, and what's this student doing with me? So that's how we pull them together, and we do that. And we actually have I think about 100 students do rotations with us across our organizations, mostly nurse practitioner students and PA students and licensed independent social workers. So that's the health center. Thank you for letting me share. Is there any questions? It scared y'all. Thank you.
Earlier I talked about also working in that bucket 3 of the larger community issues and policies. Do you have an opportunity to work on those as well?
So, so the question was, what about bucket 3? So we're in bucket 1 and bucket 2, but I'm an old public health nurse. Bucket 3 was my world. So, so we actually, I'm one of those weird people that you said no one read the Affordable Care Act. I actually did. And after, when I was reading it, I saw the Public Health Fund. I called my mayor and I said, listen, we got to get in this. We got to do it now. We got to be ready because we're going to have this money for a certain period of time and then it will go away. So I was co-chair on our, we received a small community transformation grant. And then they changed it to something else, another name, but it was pretty much the same stuff. And it was really looking at all of the things we talked, safe biking lanes, safe streets, food, access to food in food, what are they called? Food deserts, yeah, thank you. So all of those things. So we've worked with our local convenience stores that are mostly in the poor communities. And now in Lima, you go in and there are all these, this one rack of fruits and vegetables. We're in our school-based health center, and we pass out a voucher for a snack on the way home that they pick up an apple at the convenience store where they would have picked up a Mountain Dew. They're doing some of that stuff. So we have tried to work together with that, because quite honestly, we can do so much, but when people go back to the homes in which they live, in the communities where they're, we judge a lot about our patients. One of the things we used to hear is they let their kids run on the streets. They're just all over, they're out there. So what good mothers in poor neighborhoods did is they kept their kids in. They weren't allowed to run around. When I was a kid, my mom would kick us out at, after lunch and say, be home for dinner. We were free-range kids. But in poor neighborhoods, those were bad moms. So now we have moms who bring their kids in the house, and what do? Watch TV, play video games, and then they go to the doctor's office and they're obese, and you say, you're a bad mom. Well, wait a minute, my kids weren't running the streets. And that was a bad mom, and now I'm a bad mom. So there's a lot of judgments that we place on low-income people who are really trying to live within the communities at which they live and survive. That makes health a very difficult thing. So understanding that about your population is really that why that we try to get to with our clinicians and our team-based care. So.
Hi, do you anticipate utilizing community health workers in your FQHCs?
Well, my title before we started the health center is I was a neighborhood nurse, which was, it was at the same time when the health disparity was coming out, they were doing community-oriented police officers. And the concept in Lima, St. Rita's put a nurse with a cop in a neighborhood, and I actually was that nurse. And that is an expensive version of community health workers. So we're looking at our, some of the CPC money, and what I would love to do is have, the challenge is you have to have enough to actually meet the demand. So 1 or 2 community health workers doesn't do anything. I would love to have enough money to be able to do 10 community health workers, and they're generalists. They're kind of like primary care. They're not an asthma community health worker or an OB community health worker, but they're generalists. They're just those people out there who know how, when somebody needs something, they get them to it. So I would love to do that. We're not sure. I'm a little hesitant to hire a whole bunch of people when Medicaid may be gone tomorrow, but I'm feeling a little better about it. So, but I think it's a perfect model, and it is again that working at team-based care and everyone working at the top of their abilities and their license and community health. You don't need nurses to hang out in the neighborhoods and get people to appointments and encourage someone to get their kids immunized. You just need someone they trust.
Thank you so much for your presentation and for sharing your success story with us. My question is, would you mind sharing some of the things you did to invest in your staff so that they get to stay there, they get to, want to provide care for these people that are probably needy? Thank you.
Yeah. My primary care teams are led by NPs mostly and PAs, mostly nurse practitioners. So one of the things I did early on is we have so much money for CMEs in a contract, and I got all kind of grief because somebody asked to borrow my contract in the FQHC world. They said, "You're paying your nurse practitioners the same amount of CME time as your docs? What is that?" And it was really about some inequities. And I said, well, an airplane flight costs the same, no matter what your degree is. And to get to a conference, it all costs the same. So we started with some of those, just equity kind of things. Let me tell you, we try to pay our people competitive wages that I'm with the hospital, because if you don't invest in that and you don't recognize that, we don't expect people to work for charity, and we don't expect them to work for a lesser salary. But it is that allowing them to training. We also pull people out. What happens a lot of times when you're cutting costs is you stop having your meetings, you really hit productivity, and then you stop taking the time that really helps you get better. So we do lots of team planning. We do staff meetings. We have provider meetings. We work with what we call change teams. So when we have a group that's working on something, they're doing PDSAs, we allow them to come out and do that. So it's really not so much of what we do exterior-wise. We allow some people to have some freedom with their schedule if they're going back to school and that kind of stuff, but it really is more about having them be a valuable and trusted member of the team, that you just treat their time with respect.
Thank you. I just want to say I appreciate the great work that you're doing and the creativity and courage that your team is showing, especially around opiate addiction, because that is such a big issue, and it continues to be an issue regardless of all of the work that's being done. My question is around your model. With such a large number of advanced practice nurses and physician assistants to so few physicians, how are you structuring things with the statutory limitations in Ohio around the number of advanced practice nurses and PAs that one physician may have a collaborative agreement with?
Certainly. This is one of the things that kills me, other than harassing my state senator and those kinds of things. I actually pay physicians to collaborate. And the reality of it is we do all of our own internal QI. We do our own peer reviews and all that. So, my physicians take call within our organizations, but I have to go outside, and I think I have four physicians that I pay to sign a piece of paper. All right, don't anyone turn me in for anything. But really, all of the QI and the rigor is there, and it's probably, I think, last year I had about just under $100,000 in pay to collaborators for very little effort. Wow. I could do a lot with, I could probably hire at least maybe 3 community health workers with that money. So I was able to tell 2 of them goodbye with the up that just happened at the end of March. I got a whole group of people here, and no one spoke about dental, and no one's flashed any signs at me, so I'm going to take just a minute to talk about dental. Dental is, there's not enough dentists to take care of the population, and that is by design. We have certain dental schools, and only certain many people can get in, and it is always said that there will never be enough actual dentists to take care of the population. There's been a lot of communities started in countries across the world who have what they call, it's their mid-level, it's called a dental therapist, and it is the same basic model, maybe a dental hygienist who does an extra 18 months who can do a limited scope of dental work. It's been approved in Alaska. It started under their Native Americans because they don't have to go by the rules. It now is in Minnesota, Vermont, Maine, and Ohio has a legislation right now, and I think Cecil Thomas is Cincinnati, and Senator Lehner in Dayton have sponsored a bill to create this mid-level provider for the dental world, and they have very few advocates. I think the nurse practitioner world should be their advocate because for me, when I have a patient with a toothache, it's right here, it can't go away, and I have a dental clinic in Bryan, Ohio, where I'm paying $165 an hour for a locum tenant to staff my dental clinic because I can't get a provider to go to Bryan, Ohio. So I might send some stuff to Susan and ask her to send some stuff around, but it is where nurse practitioners were 30 years ago. And we desperately need that new level of provider in the dental world. And the powers that be, just like the powers that did 30 years ago, were resistant for nurse practitioners' roles expansion. This is the same thing within the dental world.
So we should thank Janice. She's done a wonderful job.
Thank you.
And I have to say, when I was in Washington a couple weeks ago and I was in Senator Brown's office, Senator Portman, she does harass them. They I told them that she would be here and they said yes.
Senator Portsman won't take any of my calls.
So we're going to take a break and then come back quickly for the panel discussion. In that, no surprise, John Auerbach's been called back to Washington right away, so he's had to change his plane ticket. And I'll let you all guess why he's been called back. But in the meantime, I also would like you to stop and look at the posters. Denise Gormley, Dr. Gormley, can you stand? She's has her UC poster over there, a shared HRSA grant with us on interprofessional collaborative practice. Also, we have exhibitors out in the lobby out there. I hope you'll stop and check out their tables. They've been very generous, help support this lunch, as well as Orbis Education over here, who we've been partnering with for a while. So enjoy your break and come back quickly before John has to leave, catch his early flight now.